All right, guys, good afternoon. Thank you for joining us for this month's installment of Grand Rounds. I have the absolute pleasure of introducing Dr. Jabraan Pasha here. He is visiting us from Tulsa, Oklahoma. So, can we please give him a round of applause? So, we've already given him a wet Louisiana welcome because his flights were a little bit delayed, but we're going to make sure we show him the warmth for the rest of the day, okay? So, Dr. Pasha, just a little bit about him before we get started. He, please correct me if I'm wrong. All right, he completed his medical degree at the University of Kansas. Then he went and did his internal medicine residency at the Mayo Clinic in Arizona. Since that time, he moved to Tulsa, Oklahoma, and has served as the Assistant Dean of Student Affairs and the Associate Professor of Medicine at the Oklahoma School of Medicine. He is one of his passions is social advocacy, and he has become a fierce advocate for health equity and community-driven healthcare solutions in Tulsa. He currently works in the mayor's office as a senior advisor for healthcare. So again, one more time, let's welcome Dr. Pasha.
I think I got. You can. All right. Good. Thank you. I'm a roamer, so I'm gonna have to. I'll probably be all up in between you all while you eat. We're good in the back. Can you all hear me? Okay. Great. Wonderful. Thanks for the invitation. Was hoping to get here last night and really kind of explore the city a bit. Didn't work out, but I'm glad to have been able to get here this morning and spend a little time with you all. As you probably know, Dr. Rumlaw invited me here. Navin is how I know him. I was his attending in residency, so I've known him for a very long time. Think the world of him, and you all are lucky to have him as one of your many leaders. So great to be here. I like you all spent most of my time at the bedside, and for me, when I thought about what is a doctor growing up, I knew I wanted to be a doctor since I was probably 7 or 8 years old. And to me, being a doctor was being at the bedside, taking care of those patients who needed that care. And that's kind of how I approached it through medical school, through residency, and even through like the first part of my time as a faculty member. But I started to kind of be kept awake at night, as they say, with one question. And that one question for me was, why are certain communities less healthy than others? That was the question that just drove me nuts sometimes, but it also just motivated me. And I know that you all serve a population that experiences a lot of health disparities. In my role back in Tulsa, I've served a lot of populations that experience health disparities. And so you understand what I mean when I ask that question, why are certain communities less healthy than others, right? And so that has kind of taken me down this path of just trying to understand what shapes health. And what we know, and we'll get into it, but what we know is that the health care that a person receives only really accounts for a small percentage of their overall health. And it doesn't diminish the hard work that we all do, but we do know that there are factors outside or beyond the bedside that actually contribute to health outcomes to a greater degree than the patient care that people receive, right? And so I want to just kind of shed some context on that and really what we should be thinking about when this talk is over and maybe continue to think about for a lot of you is what are the real factors that are shaping the disparities that really almost any city sees. Is that fair? No. So, we're going to talk about some stuff that's rather uncomfortable to talk about. And I think um, one thing that makes that a little bit easier is if you get to know the person that's kind of guiding that conversation. And so I'm going to give you a little bit of background to my family, and I'm going to ask a couple of questions. If you have five or more siblings, raise your hand. Okay. Six or more siblings, raise your hand. Okay, we're down to about three. Seven or more siblings, raise your hand. Only one left. Eight or more siblings. 9, 10, 11. Whew. You almost blew up this whole point, but all right. So, but you will understand this in ways that maybe no one else does in this room. So, my mother, born and raised in Kansas City, Missouri, okay? And she was one of 13. Same mom, same dad. So she grew up in this household with 8 sisters and 4 brothers. 13. And I remember growing up just being exposed to this really large family that looked like this. Use your imagination, right? And I remember holidays, going to visit Kansas City. I remember lots of family coming to Tulsa to visit, and I just remember this big, vibrant family. And the thing about the Black culture is we're really heavy on nicknames. So I actually don't even know that I know all of my aunts and uncles' real names. I just know their nicknames, right? And so there was Aunt Martha, which we called Massa. She was the matriarch of the family. Then we had Aunt Honey. Then we had Aunt Mary. Then we had Aunt Teeman, who was my favorite aunt. I lived with her through medical school. She was a few years older than my mom. She taught my mom how to cook. And so when I lived with her, it was just like I was living at home because the food tastes exactly the same. We had an Aunt Poop. I have no idea where that nickname came from. No one can tell me, but that's how we address her. Aunt Poop. It's strange, but it is what it is. We had an Aunt Anky, an Aunt Sean, an Aunt Sherry, Uncle Bub, Uncle Toot, Uncle George, and Uncle Fluffy. That's like my memory exercise as I get older, just try to name all of my aunts and uncles on my mom's side. But something started to happen as we grew up, as we started to lose our family, right? We lost Aunt Masa to a stroke. This was when I was in college. She was in her early 60s. We we lost, well, actually, first we lost Uncle Fluffy. He was the first person that I had known that had HIV and AIDS. He died when he was younger than I am now. I think he was in his mid to late 30s from HIV. And I was in the third grade, and I remember not knowing what it was, but remembering how sick he got. Then we lost Aunt Masa to a stroke. We lost Uncle Bub to kidney cancer. We lost Uncle George to alcoholism. We lost I forgot Uncle Toot. We have Uncle Toot as well. We lost him to head and neck cancer. None of them lived past 55 years old. Then we lost my favorite aunt, Aunt Teeman. She had multiple myeloma and heart failure. And then we lost Aunt Anky to COPD. Right? And so I remember asking, even as a young adult, like, what is it with our family that we don't live very long, right? It was a question that I recognized pretty early, like our family is dying early. But as I kind of went through my medical training and well into practice, I realized that that's not anything that was necessarily unique to my family, um, and became more aware of the social impact and the health disparities that those social drivers created, right? And so one thing I want to do I always do this to kind of set the tone of these conversations, is recognizing that it takes some empathy to talk about these things, right? And we can define empathy as just being able to imagine yourself in someone else's shoes. That's kind of how I think of empathy. And sometimes that empathy bucket gets a little bit low, and it makes, because we have so much going on, right? Most of you all are in residency or you're in medical school. Like, sometimes empathy takes a back seat to just surviving, right? And so for me, when my empathy runs a little bit low, I take a little bit of time to do what I call a privilege exercise. Okay. And what that means for me is just recognizing that we all have privilege in some form. At some point in our lives, we've experienced privilege that has removed a barrier for us. Doesn't mean we didn't have to work hard to get to where we are. Doesn't mean we've had everything handed to us, right? It just means that at some point in time, we've experienced a privilege that has helped us move forward, and there are folks that have not experienced that, right? And so I always take time before we get started in these really difficult conversations that we're going to have to just do this little exploration. And I ask myself, and I go through this with my own life to recognize the points that I had some privilege that helped me kind of move forward in my career and move forward personally, right? And I think about, growing up in a family that didn't have a lot of money, but we always had food on the table, right? We always had a roof over our head, right? We always had clothes on our backs, had a mom and a dad home, had two parents that told me they loved me, had a stable household. And when you have that, you are off to a great start. But a lot of folks that you all take care of don't have that, right? And maybe some of you in this room didn't have that, right? And that means there were barriers that had to be faced to get to where you are, right? And for me, that wasn't a barrier, and so that's a privilege, right? Being a male in this society is a privilege. I don't have to have this kind of recognition that I'm of my gender at all times in most situations, right? That's a privilege, right? Living in a neighborhood, I live in a neighborhood where there is a Whole Foods, a Trader Joe's, a grocery store called Reese's, and a Walmart neighborhood market, literally within a mile of each other on the same street. And if I were to go 20 minutes, not even 20 minutes, 12 minutes to the north, there are neighborhoods that literally have zero grocery stores in walking distance, right? So there's privilege in that, right? And so just take some time to look at this and try to pinpoint places where you specifically have experienced some privilege in your life. And again, that helps kind of reset and help you find the empathy that you need to really lean into these conversations that we're going to have today and that you should be continuing to have kind of going forward. Is that fair? Does that make sense? Right. So one of the things that really kind of pushed me forward into this health equity space was learning that in my hometown of Tulsa, Oklahoma, where I was born and raised, and in the zip code where I went to middle school and high school, there was a 15-year life expectancy gap from that zip code in North Tulsa compared to a zip code in South Tulsa. Meaning that if you were just by accident of birth, born and raised in North Tulsa, you were going to live till you were about 64 years of age. And if you were by accident of birth born in South Tulsa, you were going to live till you were about 80. And to me, it was mind blowing. I was like, what? Again, I was like, what the heck is wrong with Tulsa to where people are living these dramatically different lives and there's this dramatic life expectancy gap, right? And I started to try to figure out what's going on in Tulsa. But in that, I realized it's not just Tulsa, right? We see these life expectancy gaps all across the cities of our country, right? In Chicago, when you're comparing the north side of Chicago, which is more oftentimes more affluent, to south side Chicago, where there's more poverty, there's a 20-year life expectancy gap across neighborhoods. We see a similar gap in the Washington, D.C. area when you compare neighborhoods. We see a similar gap in New York City when you're looking at different neighborhoods and different boroughs. And now we're approaching life expectancy gaps that are 20 plus years between neighborhoods and communities. In New Orleans, which is one of the most dramatic life expectancy differences that I've ever heard, at one point, they were finding that across parishes, there were life expectancy gaps that approached 30 years. Can you imagine just the opportunity loss that comes with someone living on average 30 years shorter than somebody else, right? The contributions to the community, the joy of spending time with families, right? The financial security that could have been provided for future generations. Like there's a profound impact of communities having life expectancy gaps that are just a few years shorter, right? So imagine that compounded over decades, right? And so this is a problem that you can find really across the country. And that's why we've got to really hammered on that question of what shapes health. Why are certain communities less healthy than others? See it in Detroit, we see it in Atlanta, right? So there's this question, and I want to start off answering this question by addressing a narrative that has been kind of accepted as truth for a very long time. We are starting to recognize that it is a false narrative, and it's rooted in racism. But I want to share a quick little audio clip from an interview that I did with Daniel Dawes, who is a wonderful individual who has a lot of expertise in public health. And this short clip is just him describing his upbringing, kind of similar to what I just did, but there's going to be a very specific topic that we're going to touch on as we kind of unpack what shapes health. So it's that notion that has been kind of pushed forward for a very long time that the cause for these kind of sweeping health disparities across communities is based in genetic differences between races, right? And we know that to be absolutely false through science. That is a completely false narrative. There really is no true genetic basis for race. Race is a social construct, as they say. Another word of saying is race is made up. It was decided at some point, you look like me, you're black. You look like this, you're white. You look like this, you're a different race, right? And don't confuse race with genealogy. Those are two different concepts. And so as we've tried to kind of answer this question, we what shapes health or why certain communities are less healthy than others, it oftentimes has been easy to say, well, it's because of racial differences, and that is because of differences in genetics across races. And that's just unequivocally false, right? So to take a step back and look at how medicine has operated in our country, there's a really useful analogy, and that's this analogy of a roaring river. Okay. And so you can visualize this river. Along the banks of this river are us, the likes of us, those who are in healthcare, doctors, nurses, pharmacists, physical therapists, all of the personnel that are working to keep this community healthy. We are lining the banks of this roaring river, right, with all of our intelligence and all of our, technologies and medications, right? We're lining this river, and in the water are our patients, right? And they're struggling. And if you were to look 100 yards downstream, you know that there is a waterfall. And if they go over that waterfall, we don't get them back. We lose them. They're gone. So we work as hard as we can, tirelessly, to pull as many people out of that water to the safety of the shore, right? That's how we are currently working, right? But what should we be doing? We should be getting to those patients before they even dip a toe in the water, right? And so getting to them before they dip a toe in the water is getting to them before they get sick, right? And one thing that I'll say that I hope sticks with you is that health is not the absence of disease. Just because someone does not have an illness doesn't mean they are healthy, because health has to happen well before we treat or we prevent an illness. Health happens in the environments that someone grows up in, right, or lives in. And so when we're trying to figure out what shapes health and how we make an impact, we have to get upstream, right? And getting upstream is trying to figure out what are the social drivers that are creating these health disparities in the first place. Does that make sense? So that's what we're going to talk about. We're going to talk about this. And this is what I want us to really stick with us. This is going to be triggering for physicians, right? Because you can read it and you may think that we're minimizing the impact of healthcare, right? And I'm not. I'm not. Because when someone is sick, they need us, right? When someone is really sick, if they don't get the care they need, they're going to die, right? And so the work that we are doing is not for naught, right? It is critical work and it's important. And I'm right there with you. I'm an internist. I worked as a hospital. It's like we see a lot of sick people, right? And when they're sick, they need us. But let's be very clear on the fact that despite the way that we allocate resources, the care that somebody receives is not the biggest factor in their overall health. It's just not, right? Okay. Is that fair? So we know that there's social drivers. When you combine lifestyle and environment, that's these social drivers that contribute to someone's health. We think up to as much of 70% of someone's health is resultant from those social factors. Okay. And so we're going to take some time to kind of go through the different social drivers so we can understand how we got to this point. Like, I don't just want you to just accept that. Like, I want to give some examples of why we feel really comfortable saying, hey, these are the factors that really contribute to someone's health. If you have if you have interviewed for medical school, as in you've been an interviewer for a medical school or for residency, I guarantee you when you have asked most of those interviewees, what's the biggest problem in healthcare in our country? That answer is access to care. Like almost unequivocally, that is the most common answer when you say, hey, what do we need to solve for healthcare? And I'm not arguing that when someone needs care and they can't get it, it's not a problem. It is, right? But I'm going to tell you all through this study that was done that access to care is not the end all be all. And we have to stop pretending that it is, because I'll make a statement. It may sound bold, but I'll stand by it. I think we could put a clinic on every corner of every neighborhood. And if nothing else changed, everything else remained the same, we would see a very minimal improvement in these life expectancy gaps. And it's not just me talking. I'm going to tell you why. And it was more or less shown in this study. So this study is called the Whitehall study. This was done in the UK. It was a longitudinal study from the 60s all the way up through 2000. So like a 40-year longitudinal study in a community in London, a neighborhood in London called Whitehall. And they took all these civil servants, all these folks that lived in this community was the cohort. What historically what's important is at that point in time in 1960s is post World War II, which means there was actually universal health care in the UK. And so if you take everyone who lives in the same neighborhood, the same community, who have the same access to health care, then access to care, they all had universal health care. So access to care is actually pretty consistent across that group, right? And that's why they set this study up, right? And so they followed this Whitehall community, literally their health outcomes for 40 plus years. And then they started to look at the data and said, okay, what do we see here? And they saw kind of health outcome differences, not unlike what we see here in the US, despite there being universal health care and despite this specific neighborhood having more or less equal access to health care, right? They saw some of the same disparities that we see. They saw life expectancy differences. They saw a lot of disparaging health outcomes. And then they tried to figure out, hey, what are the reasons, what are the main social drivers for these health disparities that we see? Anybody want to take a guess as to what was the number one factor?
Nutrition.
Okay, we got lifestyle, we got nutrition. Haven't hit it yet. Tell me more. Health literacy, wasn't that? What's that? What do you mean by economy? Yeah, literally, how much money they make. That's it. That factor is the strongest contributor to someone's overall health. There is nothing else that can compete with how much money somebody has in the bank in terms of how it determines their health. And it is a direct linear correlation, which means if you take someone who, by economic um, definition, is middle class, they on average are going to have better health than someone who is lower middle class. And conversely, they're going to have poorer health than someone who fits in the upper middle class. And that's tight on that line. So imagine the differences when you're comparing someone who's living in poverty to someone who is living wealthy, right? So there is no social driver that contributes to health outcomes the way that economics does, or put in another word, how much money somebody has, right? And so they learned that we can almost, to the best degree possible, you cannot make access to care absolutely even across the board, because there's other nuances that contribute to that. But to the best degree possible, they made access to care relatively equal. And that still resulted in pretty significant life expectancy differences across incomes, right? So as we think about these social determinants of health, a better term now, I should have updated this slide, is social drivers of health. There's a kind of nuanced thoughts on why we should say drivers as compared to determinants, probably not even worth getting into, but we're going to talk about kind of the rest of these determinants or drivers. Spent a little bit of time already talking about income, and we know that that is if there's one thing you can do to impact a community's health, it is to bring more wealth and financial resources into that community, right? That's one thing we can do, and we're starting to see um, larger health systems invest in communities in that way, in ways that actually help build wealth for those communities. And it's oftentimes these are the large nonprofit health systems. We actually have a St. Francis in Tulsa that is a large nonprofit health system. They're finding ways to, because as a nonprofit, they have to do some degree of charitable giving, right? And so they're trying to find ways to improve the health of the community through non-traditional ways for healthcare, non-traditional for healthcare. So beyond just building extra clinics, right? They're actually investing um, resources into communities to build wealth. So we talked about income. Education is also something to spend a little bit of time on, and not health education, not health literacy, um, just education in general, right? Actually has a bigger impact on health than health education, if that makes sense, right? So education operates in a very similar fashion to income. It's not quite as it's linear to a certain degree, but there's a threshold. And that threshold in terms of the benefit that you get out, the health benefit that you get out of education stops at about a college degree. So sorry, a lot of doctors and masters in this room. The benefit to health from education stops at an undergraduate degree, right? And so we know that on average, someone who has achieved an undergraduate degree is going to have on average better health than someone who has not, right? And again, as we kind of think about privilege and how, our own experiences can kind of cloud, our insight to others, you may say, well, the college degree doesn't seem that hard to get, right? And it wasn't for me because of the privileges that I, benefited from growing up. But we have to think about, at least in the U.S. and how the public school system in the U.S. is funded. Does anybody know how schools, public schools, K through 12 are funded in the U.S. primarily. What's that? There's some whispers. Yeah, yeah, exactly, right. It's two primary sources, right? It's income tax. Sorry, it's property tax and sales tax from that neighborhood, right? And so looking at sales tax, that's sales tax from the businesses in that neighborhood. So how are we generating significant sales tax dollars in communities that don't have a business base, that don't have stores and restaurants and opportunities for commerce in those neighborhoods, right? You're not. You're not generating a lot, right? And then property taxes, right? And think about wherever you're from, or if you spend enough time here, think about the differences in property values across parishes or across a certain community and how they can be dramatically different, where you may have some communities where the property values are going down and other communities where the property values are going up, right? So we know that it can be a challenge because to build really strong schools with really good outcomes, they have to be well resourced. Well, the resources come from the tax base, and if that neighborhood cannot generate a strong tax base, there is some significant challenges for public schools to provide what the students need to be ready for those next steps. Right? And you can tell a big difference from someone who's graduated high school that is under resourced in their college readiness and someone who has gone to a private school or a well resourced public school and their college readiness. And so that bar of a college degree is at different levels depending on where you were educated or the time that your family was able to spend with you or the resources that your family had to put into you um, in addition to what you were getting at school, right? And that's guided by different social factors as well, right? So although it may feel like a college degree that's not shouldn't be that difficult for some, it's impossible. It's not even realistic, which is sometimes hard to wrap our brains around when we're folks that have gone to medical school and are in residency and are practicing positions. So education plays a significant role. Early childhood is also critical, and it actually there's kind of some specific kind of boundaries that we know are really impactful, and that's birth through 8 years of age. So we know what happens to a child between day zero to 8 years of age is critical in shaping not only their behaviors as an adult, but also their physical health as an adult. Okay? And we have something called adverse childhood experiences, or ACEs for short, that essentially acts as a kind of a tally system in terms of poor experiences that a child may have had. And as those tally marks go up, so do the likelihood of having poor health as an adult. So what a child experiences as a child impacts their health as an adult, right? And so if they live in a household where they experience abuse, whether that's physical or sexual or emotional abuse, those are tally marks, right? If they are neglected anyway, emotionally or physically, those are tally marks. If there's any kind of dysfunction in that household, whether that's substance use, mental illness in that household, if their parents are separated or they're raised by a single parent, relative that's incarcerated, if they experience any domestic violence in that household, those are tally marks. And that is a directly linear correlation. So the higher the ACE score, as it's called, the higher the risk and the likelihood of poor health outcomes as an adult. We know that if the ACE score goes up, then as an adult, there's increased likelihoods of having obesity. There is increased likelihood of mental illness. There's increased likelihood of poor performance in school. There's increased likelihood of having a poor kind of work record. Um, what happens to these kids manifests not only through kind of their growth, but it also manifests in physical health in adulthood with high rates of diabetes and heart disease as well, right? And so those social factors play, or sorry, those childhood factors play a major role as well. What happens socially is also critical, and I'm going to be careful here because this is recorded with about what I can say. Right, we're in a place right now where there's things we just can't say, given the current political climate. But we know I don't want Navin to get in trouble, so we're gonna just keep moving here. But look into things like bias in healthcare and how that can impact it, and make your own decisions. How about we'll do that. There's something called generational trauma. We used to think, and I say I think probably within the last 10 to 15 years, we've developed a better understanding of how trauma impacts future generations. And the thought used to be that if an individual experiences trauma, the way that that trauma is passed down to future generations are through the behaviors that the first person learned to help kind of navigate those traumatic experiences. So it may not be good for that person in the long run, but it's self-preserving in the moment. And those behaviors can then be passed down, if that makes sense. And we thought that's why, certain traumas can then impact future generations, mainly through practices and certain behaviors. And that does happen and that does contribute. But what we know now is that when an individual experiences a trauma, and if that trauma is severe and life altering, especially, that trauma actually can change that individual's DNA. It's called epigenetics. And there are tags that are placed on genes that turn genes on or turn genes off. And we didn't know that a change to a parent's DNA can be passed down to offspring, but it can, right? And so this was first kind of started to be recognized when they looked at survivors of World War II, soldiers, survivors of the Holocaust, where they noticed increased rates of mental illness or substance use or chronic disease in the generations that followed the folks who survived, these tragedies. And they have since learned the why behind that, and it's because of these epigenetic changes to the DNA that was then passed down not only to the kids, but to the kids' kids and the kids' kids' kids now, right? We would expect that to also be the case as we look at, our Native Americans who were kind of ripped from their cultures and placed in boarding schools across different parts of the country. Obviously, I'm from Tulsa, which is the largest city that is entirely on Native land. The city of Tulsa sits entirely on Muskogee Nation and Cherokee Nation, right? And so we have the largest population of natives of any state. And so, these are things that we have to think of as we look at higher rates of alcoholism, higher rates of diabetes and chronic disease, as we see in some of the native tribes. You would also expect to see that with other forms of kind of domestic terrorism. I'm from Tulsa, and if you are from Tulsa or know a lot about Tulsa or spend a lot of time in Tulsa, you can't do that without learning about the Tulsa Race Massacre. So this was in 1921. Tulsa had a part of town that was known as Black Wall Street. It was the most wealthy Black community in the entire country. They were wealthy primarily from oil money that was then kind of reinvested in that community. And it was at a time where they couldn't go anywhere else. So all those dollars recirculated in that community. And there was wealth in North Tulsa, unlike anywhere else in the country. because of that oil money. There were many Black millionaires and business owners that were kind of born from this wealth. And in 1921, there was some jealousy that was kind of brewing from the white community towards Greenwood, or Black Wall Street, as it was kind of affectionately referred to, that resulted in a series of events over a couple of days that left the entire 37 blocks of Greenwood burned to the ground. And so it used to be referred to, when I was growing up, it was referred to as the Tulsa Race Riot, which kind of implicated both sides as being at fault. We now know that that wasn't the case, and it's referred to as the Tulsa Race Massacre. And so, we had folks who survived that but lost everything. Right? They lost loved ones. They lost their well-being. They lost any chance of financial success. And so, as we think about generational trauma in Tulsa, where we have many survivors, descendants of survivors of the Tulsa Race Massacre, I can't help but ask, how do those epigenetic changes still impact the health of the folks who are living in Tulsa because of what we know about generational trauma? That's what it looked like after the race massacre, literally leveled that entire community. What we now are, I think, doing really well is understanding the impact of a neighborhood in its entirety. Just think of everything that a neighborhood can bring as it pertains to shelter and places to eat and places to socialize and parks and sidewalks and street lights and community, like everything that a neighborhood brings. We're starting to realize that really maybe if we could boil all of this down to like one thing that can really make a huge impact, it is creating a neighborhood that can foster those things, right? Like, think about this. I don't know. I think of analogies a lot, and like how to like put this in pretty digestible terms. Think about a plant, okay? And if you don't have a green thumb, I'm not saying I have a green thumb, but like we've all maybe tried to grow a plant and trying to figure out like, why are the leaves turning brown, or like why are the leaves falling off? Why is it leaning to one direction, right? You can address those things. Let's say that plant's got a little fungus on one of the leaves, or that leaf is falling off. You need to prune it, get that leaf cut off, right? If it's wilting, well, it probably needs a little bit more water, right? If it's leaning towards the window, it's probably not getting enough sun, right? Like those are things that you can address in the moment and maybe make that plant have a little bit more success, right? But what about the soil? Right? If the soil was crap, if it just didn't have what that plant needed to thrive, it doesn't matter what you're going to be doing. It's all band-aids at the end of the day, right? Well, that's how we have to start thinking about health, right? Because if the neighborhood is not a neighborhood that's conducive to health and well-being, then coming to see us in our office is just a band-aid, right? Because we're sending them home to a neighborhood that just can't keep them healthy, right? And so we have to start thinking about how do we address kind of all of these things from a neighborhood level. And we know that the neighborhood is the key. We're starting to really address that by investing more into neighborhoods. That's why I'm so proud of kind of working in the mayor's office in Tulsa, because our mayor understands the impact of a neighborhood and how we have to invest in these communities and the places that people live and work and play and worship to help generate health and well-being, right? And so, I want to be very clear. I always try to have some insight to when I kind of do these activities, these exercises, that there may be folks who don't have to walk through this activity or exercise because this may have been, something that they've lived, right? And so if that were the case, you don't need to go through this activity because you've experienced it. I'm sure there's always someone in the room who doesn't need to close their eyes and imagine what I'm about to present. So I always want to call that out. So this is a neighborhood in North Tulsa, and if we drove around, matter of fact, coming from the airport, Carla took me kind of all the way through the neighborhood, not necessarily on purpose, but we drove kind of all through the community, and I saw homes that looked like this, right? So whether you have seen them or lived in neighborhoods that look like this is, for those of us who haven't, it can be really hard to imagine living in a neighborhood where you have homes that are next door to you that are boarded up and vacant, right? And maybe unsafe for a lot of reasons, right? Sometimes it's hard to just imagine that. And so if it is something that you have to imagine, like myself, think about how the priorities of someone who has to live in a neighborhood like this may be different from the priorities of someone who lives in a neighborhood that has this spoil of resources and wealth, right? Just think about that, right? How the priorities might be different. So let's do this little activity. I think we're okay on time. So one thing that stood out in Tulsa as we were kind of exploring that life expectancy gap was there was a significant food desert in North Tulsa. And before 2.5, 3 years ago, there literally was not a grocery store in North Tulsa. And so for someone who relied on public transportation to get from a certain neighborhood in North Tulsa or certain neighborhoods in North Tulsa to the nearest grocery store and back home could take as long as 4 hours. 4 hours, which is not reasonable. So did people do that? Not many, right? So what did they do? Well, they lived in a neighborhood where there was lots of fast food. And they lived in a neighborhood there where there was a spoil of dollar stores. So many so that the city council in Tulsa put a moratorium on the building of any more dollar stores in North Tulsa. Right? So you can literally walk out of your door almost anywhere you live in North Tulsa and go any cardinal direction. Within a mile, oftentimes much sooner than that, you're going to hit a dollar store. Right? And so if that's all you have, that's what you're going to do. Right? So imagine this scenario. Close your eyes if you need to. Imagine a single mom who has to work two full-time jobs, a regular shift and an evening shift, to take care of her two like growing teenage boys. Okay. She doesn't have her own transportation, so she relies on public transportation or friends when possible. She lives in one of the neighborhoods that I talked about where there is no grocery store. And in between her first job and her night job, she's got a couple of hours to figure out how she's going to put food in these kids' bellies, right? She can't, she doesn't have 4 hours to get on the bus and go to the grocery store, right? And if she did, she may not be able to afford the healthy food at the grocery store. So what does she do? She does what any mom would do in that situation, right? Is go walk out her door in any direction she chooses, and she's going to go to a dollar store. And she's going to walk down the aisles, and she's going to see an aisle like this, right? And what stands out to you all when you see this picture? Say again. Cheap, and it's crap, but it tastes good. And are the kids going to complain about it? No. Like those are all factors to consider, right? So she's going to buy this cheap food that's going to fill up her kids' belly, and they're going to be pretty excited about honey buns and orange pop and Swiss rolls, right? They're going to love it, right? But is it making them healthy? No. Like, what is it doing to their brains? Who knows? Or maybe we do know it's not good, whatever it is, right? But the decisions that people make are reflective of the choices they have, right? And so when we're yelling at our patients to get their blood pressure down and they need to eat better, they need to go out and exercise, right? Well, do they even have access to the foods that we think they should be eating, that we know that they should be eating? Maybe not. Do they live in a neighborhood where it's safe to walk, right? Do they get off work at a time where they can go out and walk? Are there sidewalks? Are there street lights? Are there loose dogs in their neighborhoods? That's the one thing we found out in our community engagement to why folks aren't out and about. In Tulsa, it's loose dogs, right? I bet you it's not any different here, right? One of the main things that we found out about why kids aren't going to school, it's loose dogs, right? Because it's not safe, right? So all those are factors as to why communities cannot be as healthy as they can, right? And it all starts with the neighbor. And then the final social driver I want to talk about is a new one. And this is kind of from the work of the guy that you all heard, Dr. Daniel Dawes, is that we can link any social driver to policy or policies that make it able for folks to be more healthy or less healthy, right? And so we there's we we used to be able to say, oh, we're doctors, we don't need to get into politics. But if you know that it's these social drivers that are impacting the health of your patients, I would argue the exact opposite, right? You took an oath, right? And it's to help care for your patients as best as possible, right? We don't need any more warm bodies in medicine, right? We need folks that are motivated to advocate for their patients, and that goes beyond advocating for them at the bedside and showing up for them in clinic or in the hospital. Like, we have a responsibility. We do. We took the same oath that I have, right? It hasn't changed. And so my argument is that no, because we know the impact of policy on our patients' health outcomes, we have to find ways that we can individually advocate for them beyond just what we prescribe for them or what recommendations we have for them. And that doesn't mean that you all need to go to the Capitol and shake a sign and talk to a senator or a congressperson, right? There are a lot of different ways that you can advocate, and you have to figure out what your strengths are, what you're interested in. But we can all do something that can help kind of shift the political tailwinds to make it so that our patients can be more healthy. 'Cause we're heading in the wrong direction now. It's going to be increasingly difficult to keep our patients healthy because the conditions, the soil that they live in is going to spoil even more, is what the expectation is. And so we've got to find ways to use our social capital, political capital, to continue to advocate. So I'll step off the soapbox there. But I mean that. And I think we do have a responsibility to do more than just see patients. So what now? Like, right, it's trying to figure out that. I think that's part of it. Um, we also, I think, are starting to get a lot better at screening for social needs of our patients. Most health systems have means to do that. A lot of nonprofits, a lot of community organizations have means to now screen for social needs. We also need to connect folks to the social needs that they may have. There for a while, we would just be like, "Are you having trouble getting food? Are you having trouble paying your bills?" Okay, thanks for letting me know. And that was it. Like, there was no next step, right? And that doesn't help anybody, right? So we need to also have a plan to how do we utilize the social services that are available in the community to get our patients what they need to be well and be healthy. 1 minute, maybe two, to talk about how we're approaching it from. So like the hat I'm having now is the health equity work, and I go all over and talk about this stuff. But my like job is as the chief health officer for the city of Tulsa, and we are really leaning heavy into neighborhood-based, uh, initiatives. And I think the other analogy that I would do, the last analogy for me for the day is if you think about a shovel and how much, especially if that dirt is hard and hasn't been watered and doesn't have a lot of nutrients in, like how hard you have to step on that shovel to get deep into that dirt, right? It takes a lot of force, or another way of looking at it, it takes a lot of resources to really get deep across a broad area, right? But if you have a little hand trowel, right, it doesn't take a whole lot of force to get deep into that dirt, right? And that's how I look at neighborhood-based work, because if we're doing citywide initiatives, you could do them, but for them to be like impactful, it takes a lot of money, a lot of force, like a lot of resources, right? But if you're doing it kind of specifically neighborhood-based or place-based, you can have deeper impact with fewer resources, right? And so that also allows you to start to recognize which neighborhoods need the most support and focus your resources with those neighborhoods. So we have a tool. I'll send it to Navin. You guys can look through. It's called the Neighborhood Conditions Index, where the city of Tulsa is divided into 80 neighborhoods. You can click on any of the neighborhoods. You can get racial ethnic data. You can get age. You can get demographic data. You can get median household income. You can get education data. You can get the type of housing that's in that neighborhood. And there's another tool that's built onto it that has 9 categories that looks at social drivers at the neighborhood level. So you can click on a neighborhood and it'll tell you the health insurance rates of that neighborhood. You can click on that neighborhood and it can tell you the distance to the nearest healthcare. You can click on the neighborhood, it can tell you the number of parks and green spaces in that neighborhood, and right. And so it just allows us to figure out the social driver kind of position that each neighborhood is in. And as we design initiatives that are pulling resources to address these, we can kind of target the neighborhoods that need it most. And I could talk for 2 hours about that because I'm really excited about it. But that's what we are trying to do to address that question of like why certain communities are less healthy than others. So I'll stop there. I know we're right at time. Maybe we can take a couple questions. That's okay. If you have any. Yeah, please.
Threshold for the education, like an undergraduate degree, and then that matters for the health outcome.
Yeah.
Do we know any threshold for the income? Like,
Good question. He asked, we know there's a threshold for education in terms of once you hit an undergraduate degree, you kind of squeeze everything out of education that contributes to health. Do we know if there's a threshold for income? No. And what I mean is, from what I have learned, there is no threshold. Like generally, the more wealthy you are, the healthier you're going to be on average. So there doesn't appear to be any meaningful threshold as we look at income. Yes. Thank you. Yeah. Yeah. Mhm. Yeah.
What are the few things that we can teach our, doctors of tomorrow
Yeah.
to actually come to the table rather than be on the menu?
Yeah, good question. Like what can we do, right? What can we teach our future generations? I think one is making sure our medical students and residents like understand that there are factors outside of clinical care that impact health, like we're doing today. I think that's big. We got to teach them what advocacy looks like. Right? Some folks think that advocacy is only going to the Capitol and talking to your representatives, right? No, advocacy can be writing an op-ed about a patient's experience to just try to motivate folks to have empathy and recognize privilege. Advocacy can be utilizing a social media presence to educate someone during a pandemic on how certain folks can stay healthy. I mean, that's one thing that I did. I wasn't in the COVID unit, and I'm like, how can I contribute? And for me, it was updating every single day COVID, so they had it from a trusted source, right? So social media is a big place. It could be volunteering. It could be helping to start clubs or programs. Like it's just helping folks recognize there's a lot of different ways to advocate. You don't have to do something you're uncomfortable doing. You don't have to do something you're not good at. Like if as long as you have the insight to know like what are your strengths and what do you like to do, you can find a way to advocate for a cause, whatever that cause may be. And you can apply this beyond medicine and health, right?
That access to food stamps or things like that that help them fulfill that role, does that change their outcomes in terms of health?
Yeah, it plays a small part. This stuff takes so much time to bear fruit, right? But we know if you have a community that does have access to fresh and healthy foods, um, becomes less reliant on fast food and processed food, that you do see an improvement. But you also have to help them learn how to cook these fresh and healthy foods. So some of the best evidence comes from food as medicine programs, where they enroll, they provide fresh and healthy foods, they teach them how to cook it so it tastes good. And there's one program specifically that I'm referring to called Fresh RX, where they've seen dramatic improvements in diabetes A1Cs for enrollees into this program. So on the small level, yeah, we know that it works, but it takes an effort. It can be quite intensive. Right? Good question. I'll make sure that you all have access to my email. Feel free to reach out if there's any questions that you didn't get to ask today, but thank you. It was great to be here.
Thank you very much, Dr. Pasha. Dr. Pasha made some very, very good points today, especially, how important it is for us to be cognizant of the patients and the communities that we take care of. Being a physician is a position of privilege in itself, and it's important to recognize that our reach goes beyond the clinic and the outpatient setting. So once again, can we please thank Dr. Pasha for his presentation? We would love to have you back in.
I would love to come back. I want to